So thank you very much for the invitation and opportunity to speak to you about something that's very near and dear to me. I'm going to review some of the same concepts that Dr. McKim alluded to this morning. We'll apply them as best we can to pediatrics. The first thing I need to tell you is that there's not a lot of evidence or a lot of study to guide a lot of the things we do in medicine. And this is extremely true in looking at children with a variety of neuromuscular conditions. I kind of hope that will change over time. I think there are a lot of good therapies out there, but we're learning from our adult colleagues and we're learning more about what we can do to support breathing in children who are affected with neuromuscular conditions. So first, just a review of the broad concepts and the type of respiratory problems that people with neuromuscular conditions can run into. And that's going to really guide our discussion as we talk about the different types of therapies and the problems that they target. So one issue is that the respiratory muscles tend to weaken in conjunction with the other muscles of the body. And when that happens, your chest wall becomes restricted. It's very hard to take a deep breath and get enough air into the lungs. The second thing that can happen is that because nobody breathes as deeply when they're sleeping as they do when they're awake, the children may start to underbreathe or not breathe as deeply as they need to when they're sleeping. The second thing that happens, often concurrently, is that cough gets impaired. And when cough is impaired, you have a lot of difficulty clearing out secretions, particularly at times of infection. And gobs of mucus or secretions can block parts of the airway and cause different portions of the lung to collapse, similar to what the pictures were that Dr. McKim showed you when he was looking at the x-rays. And the last thing is that children with neuromuscular conditions are not necessarily more at risk of chest infections, but they may handle them differently and may need some extra support during those times. It's important to realize that not everybody progresses at the same rate. Some of the conditions will progress more rapidly. Some people with the same condition may progress at two very different rates and may need different supports at different times. So let's start by looking at impaired cough. In general, if you look at neuromuscular conditions and how they tend to progress and how the respiratory muscle involvement tends to progress, initially, many of the children or young adults may have very normal respiratory function. They're able to cough and clear secretions, they handle colds very well, they breathe just fine at night. The first thing that may become an issue is a bit of a weak cough, which may initially manifest as coughs and colds that may be cleared in 2 or 3 days in somebody else that last a lot longer. So I often get the history from a patient in the clinic that comes in and says, you know, I'm doing really well, my breathing tests are normal, and when I ask the question, well, how many colds and coughs have you had in the past year? They may say, we had 2 colds, and how long did they last? How long did they take to get over it? And suddenly the answer is it took 3 weeks. It was really hard to get over that cough and cold. And there are some things that we can do to support that we'll talk about a little bit later. The third thing that can happen, and often these don't necessarily follow this perfect order, is that the breathing problems during the night can start to manifest, and we'll address those later on. And eventually, there can be breathing troubles, as you've heard, both awake and during sleep. If we look at how we cough, I think it's helpful to understand how a cough is generated to know what the different components of the cough are so you can know what things we might target when we're trying to improve or strengthen somebody's cough. The first thing you need to do to cough is to take a deep breath, and that means contraction of your diaphragm and your intercostal muscles, the muscles between the ribs. You close your voice box to keep that air in there, and you squeeze your abdominal muscles to generate a lot of pressure. And then you suddenly open your voice box and the air comes flying out, and hopefully along with it takes all the mucus and debris that's in the airways and moves it outwards. In people who have neuromuscular conditions, this is a problem on several levels. The first is that if your inspiratory muscles are weak, you don't get that deep breath. You don't get enough air in to be able to generate that pressure to develop the expulsive force to cough. There may not be enough force to expel the secretions from the airways. The chest wall itself may be stiff, and even if your lungs were able to expand, if the bony structures have become stiff and the muscles have become stiff, you may not be able to stretch them enough to get that deep breath. And lastly, you may have decreased lung volumes over time, means that if the lungs aren't opened, they're kind of like a balloon. And if you think of a balloon that's been stuck closed for a long period of time, it becomes really sticky and it's hard to open up, and the lungs are very much the same. So when we look at impaired cough, there are a couple of things that we can do first to evaluate it, and we'll talk a little bit more about the pulmonary function test, similar to what you saw already this morning. And then we'll look at the things that you can do to help improve cough and to support somebody during infections. So this should hopefully be a bit of a review. I think this is the same picture that Dr. McKim showed you before. There are a number of different things that we measure in the clinic. There are a number of different numbers that we look at. There are normal values that exist in children for many of these numbers, but some of the fancier ones that really get at the questions we're truly asking about how effective someone's cough are difficult to measure in children. Difficult because they're technically difficult to perform, and difficult because we don't necessarily know what a normal value is for a 6-year-old compared to an adult. So the ones that are routinely measured in most centers are total lung capacity. How much air is in the lungs at maximum inspiration? The forced vital capacity. How much air can somebody get in and out of their lungs when they're breathing deeply? And the forced expiratory volume in 1 second. How much air flows out of the lungs in that initial when they blow out? What's more targeted to respiratory muscle strength and how effective somebody's cough is are these maximal inspiratory and expiratory pressures. There are norms for these in children. They do exist. I will tell you that most centers are not using them. We do measure them, and we use them more as a way of tracking whether things are changing. Some guidelines will include maximal expiratory pressure as a measurement that lets them know whether somebody needs some additional support for their cough. We'll come back to that too. The cough peak flow, again, something that's starting to catch on in pediatric centers, but hasn't really been the mainstay of a routine assessment, I don't think, in many centers. This maximum insufflation capacity tells you if you were to stretch the lungs with the aid of some form of lung volume recruitment, how much air could you actually get into the lungs? And that's that concept of that MIC-VC difference. How stretchable or expandable are the lungs themselves? The spontaneous VC is just another way of saying forced vital capacity. So in somebody who has an impaired cough, there are a number of different strategies that we can employ to try and support them. The first is to prevent the cough or the respiratory exacerbation from happening in the first place. Now, that doesn't mean that somebody needs to be cared for in a bubble. Doesn't mean that you can prevent every respiratory infection even if you did your best. But the things we can prevent, we do. So vaccination becomes extremely important. We recommend that all of our children receive a flu shot on an annual basis and have pneumococcal vaccination. The pneumococcal vaccines or Prevnar is now part of normal routine baby vaccinations, but that's only been implemented routinely across Ontario anyway in the past 5 to 10 years. And certainly children before that would have had a different type of pneumococcal vaccination that sometimes needs boosting periodically. So important to watch out and make sure that we have prevented as best we can those types of infections. Pneumococcal infections are the most common cause of community-acquired pneumonias. The second thing, which seems intuitive, is to avoid sick people. So if you're going into an environment where you know somebody has a cough or cold, probably not the best thing for somebody who's a little bit more susceptible to the effects of an infection if they do happen to catch something. And recognizing that this is not perfectly possible, we then need to support people who do have trouble with impaired cough, and that brings us to lung volume recruitment and airway clearance techniques. So as you've already heard, the principle behind lung volume recruitment is really a stacking of breaths to increase the amount of air that's in the lungs. That helps that first phase of the cough so that the lungs are better expanded and you can generate a more forceful cough. This is just a different picture showing you the same idea, that if this is a vital capacity, so the most air that somebody can get in and out of their lungs, if they breathe in as deeply as they can, and then you add extra breaths on top of it and have them hold it, suddenly they've got a lot more air in their lungs. There are different ways of providing lung volume recruitment. And you'll see as we go along, there's no head-to-head comparison of these devices. There's no one right way to do it. And what's right for one person at one time may not necessarily be the right thing for them at another time. But just to give you an idea of the technology out there, and these are not the greatest pictures in the world, there's the cheap low-tech version. which is a self-inflating resuscitation bag with a one-way valve in it, and it has a mask. The video you're going to see a little bit later on uses this in order to demonstrate how lung volume recruitment can be given with it. The nice thing about it is the person who's applying the pressure can squeeze until the patient looks like they're getting full and can adjust very rapidly how much air is delivered with every breath. It's readily available, although it has to be distinguished from a bag used for resuscitation. This cannot be used for resuscitation purposes, and that's very important in labeling it. It's an inexpensive device. It's not very pricey at all. And the nice thing about it is it's small and portable. It's about this big. Now, granted, the technology is catching up, but it still is not quite as easy to cart around. The Anexaflator, or cough assist device, mechanically provides the same positive pressure breaths to stack air and to get a deep inflation of the lungs, but has an added feature of a rapid negative pressure to help generate a cough. This is not fully covered by provincial insurance plans, although as you've heard, there is a lot of support that's being provided through the Muscular Dystrophy Association to help people access this therapy, but it is expensive. And it's cumbersome, although less so with the newer models, and it's less portable. The one thing it does have going for it to date is that it's better studied. But when I say better studied, it's not perfectly studied. Regardless of how you're going to provide this therapy, the general principle is the same. I'll walk you through the procedure and I'll show you a video of what this actually looks like, and then we'll get into the evidence behind how effective it might be. So via a face mask or a mouthpiece, either interface would work, with an ambu bag or with a cough assist device. The pressure settings, there's no perfect guidance as to how much pressure is the right amount of pressure. And this, again, needs to be very individually titrated and individually assessed. In general, we have our respiratory therapists look at how much the chest moves and how expanded the chest seems to be. We also look at the patient's comfort. And when the lungs get to be stretched enough, the patients start to feel that stretch. And that's when we generally know we've reached the maximum that they can hold. Patients will stack 3 to 5 breaths depending on how big a breath and how much they're able to do. And we try to coordinate this with the patient's respiratory pattern. So in other words, the patient takes a breath at the same time as you're squeezing or applying pressure to help them get a deeper breath and stack it. And as you saw before, this can be followed either by a spontaneous cough or a manually assisted cough with an abdominal thrust, or in the case of a mechanical Anexaflator, there's that negative pressure that's generated as well. We tend to have our patients do this 3 to 5 cycles as much as they can tolerate it, and sometimes suctioning is needed as well. Sometimes the machine will help to bring the secretions into the mouth or into the back of the throat, and the patient may need some help to actually expel them. Okay, so let's see if we can get this video to work. Hopefully I can show you what this looks like. And I don't see Melissa in the room, although she is here today. Oh, we're missing sound on our video.
Your exhalation, your breath stacking, and make sure you make eye contact with them so we know when you get that nice stretch, okay?
Okay, so I'm going to breathe into your eyes. You can get you put your chin up. Okay, breathe out. Apply some pressure and look right into your eyes, okay? So breathe in. Breathe in.
So you can see that he's squeezing as she breathes in. And if you watch her chest, you can see that it rises a little bit. Now, Jordan is very expressive. You can see she tells you with her eyes when she's had enough and things are too full.
Put the mask on. Pressure tight. Right. Breathe in. Breathe in. Breathe in.
There's a lot that you can't get.
Okay, so I'll try again.
So getting the fit just right is a bit finicky, but important, because otherwise all the pressure you're delivering is leaking out the side and you're not giving what you think. There are different approaches to how often and how much is the right amount to be using this therapy. We'll come back to that a little bit soon. One thing that should be noted is that if you're going to do this, you want to try and do it before meals. Somebody who has a very full tummy, some of that air that you're blowing in is going to be swallowed, and it can give you indigestion or reflux. So certainly try to avoid doing it around mealtime. And if somebody has a G-tube, we'll often take advantage of it by letting it be open so that any air that does get swallowed can come out and it doesn't cause any discomfort. So I'll watch this one last time just to see her get the technique right. So Jordan doesn't give a very strong cough at the end of this, but you can get the impression at least about how much her lungs are inflated by it. When a patient has lots of secretions, we get them to cough, and that will help to dislodge things as well. She's quite well at the moment, which makes it a little harder to demonstrate that portion of it. So in terms of what we're trying to achieve when we use these techniques for lung volume recruitment, there are a few benefits that we might have with it, and things that, based on what we're doing, we would anticipate would be helpful. The first is to improve the efficacy of a cough and help to get the secretions out. The second is to maintain chest wall compliance and range of motion. So much like that picture that Dr. McKim showed this morning of the muscle that's not stretched becoming tight and narrowed, we want to avoid that in the case of the respiratory muscles as well. In doing so, we think that also helps to maintain the compliance or stretchability of the lungs themselves. And in doing so, we hope that this might actually maintain lung function over time. The other thing is that this doesn't necessarily have to be a treatment in isolation. It can be an adjunct to physiotherapy and an adjunct to suctioning. So for example, some of the children that get hospitalized with lots of secretions will have a session of physiotherapy first to dislodge all the secretions and move them into the bigger airways. Then they'll do a session of lung volume recruitment to move them up and out. And if necessary, they may be suctioned to get the secretions the last bit of the way out of the mouth. This is a very safe therapy. In looking at hundreds of patients using this over probably 30 years of experience in some centers, there are really very few complications that have been reported. There is a single case report in the literature of 2 adult patients, one of whom had Duchenne muscular dystrophy, who developed a pneumothorax or a leak of air outside the lung while using mechanical inexsufflation. This is with very high pressures. And in truth, these patients had other risk factors for development of pneumothoraces. There are no reports in children at all of pneumothorax that's directly attributable to using lung volume recruitment or mechanical inexsufflation, so it's safe. In terms of the evidence that we have that this is beneficial, it's a little bit challenging to tease out. And I say that because in many centers who have been big proponents of bringing this type of treatment to the forefront, it's been done at the same time as a lot of other things were implemented. So teasing out the direct benefit attributable to the lung volume recruitment therapy or to inexsufflation is a bit challenging. But we know when it's implemented as part of a plan of care, it can decrease hospitalizations, decrease pneumonias, prevent episodes of respiratory failure, and decrease the need for tracheostomy. These studies are largely done in older teens and adults. There's only one small study looking at lung volume recruitment in children, and it does suggest that there's some benefit. But that study was not intended to look at long-term outcomes associated with it, so that's still a question mark. In terms of how effective this is at preventing the restriction of the chest wall and maintaining that stretchability of the lungs, we really aim to maintain that range of motion. Again, difficult to assess over time, but there's one case series, so a group of patients that were followed up to 24 years, so a very long period of time, and a large group of patients, 282 of them, with different neuromuscular conditions. And these are mostly adults, so we really don't know in children. But in that group, the maximum insufflation capacity, how much air you could actually put into the lungs and how much you can stretch the lungs, was maintained even as their vital capacity, how much air they could do by themselves in and out of the lungs, was decreasing, which suggests that the lungs are still stretchable even as the respiratory muscles weaken. Dr. McKim and I had a look back at his experience using lung volume recruitment, mostly within ambu-bag, in adults with Duchenne muscular dystrophy. And we looked at the time period before lung volume recruitment was introduced and the time period after lung volume recruitment was introduced. This is a retrospective study, so looking back in time, again, other things may have changed in the course of these patients' treatment, although we didn't really think so. And we have at least 2 years of follow-up before and after. This is the trajectory of forced vital capacity, that main lung function measure that we look at, before lung volume recruitment was introduced. After it was introduced, the rate of decline really flattens. We had a 90% reduction in the rate of decline per year in patients with Duchenne muscular dystrophy after this treatment was introduced. This was being used at least twice a day on a regular basis. Granted, it was in adults with more advanced lung disease than children might have, but really this is the first evidence that we have that it can maintain lung function. So if we look across the country and we look to other countries to decide what the standard of care is or should be, it becomes really murky. So lung volume recruitment has been recommended by Bach, who's been a big proponent of this treatment and really probably the first to introduce it in a plan of care for patients, and Finder, who's a prominent pediatric pulmonologist in the States, as a standard of care in neuromuscular disease. But if you look around the world at what people are doing and how this therapy is rolled out and who's using it and who's not, it's very variable across the country. And the truth is that in many cases, there just isn't enough evidence to convince people that this is a worthwhile endeavor. So if we look at what the American Thoracic Society recommended, they came out with a statement on respiratory care for patients with Duchenne muscular dystrophy back in 2004. They recommended that DMD patients should be taught airway clearance techniques and how to employ them early and aggressively, although they don't really qualify what early or aggressively is. They provide guidance in terms of what cough peak flow measures or that maximal expiratory pressure measurement of respiratory muscle strength should be cutoffs below which these therapies should be introduced, but these are in adult patients. We don't know in a child whether a cough peak flow is achievable for a 6-year-old of that force. So the committee strongly supports the use of mechanical insufflation, exsufflation. They didn't really consider the manual methods within ambu-bag, but in general they support the concept that this should be employed. More recently, the Center for Disease Control in the States also brought together a group to revisit this issue of respiratory care for individuals with Duchenne muscular dystrophy. And they put a few more numbers on this. So they suggest that either manual or mechanical lung volume recruitment when the forced vital capacity is less than 40% of predicted. They don't say whether this should be with coughs and colds, on a regular basis, how often. They certainly are big proponents of it when patients have respiratory infections and have impaired peak cough flows. When the baseline peak cough flow is less than 160, and again, that's a number appropriate for adults. We're not sure for children if that's an appropriate cutoff, or that maximal expiratory pressure less than 40. They provide a bit more guidance looking at the older teens. And what you may notice here is that they don't talk about peak cough flows in the younger patients, largely because we don't really entirely know what's normal. But in general, as lung function declines, it probably should be introduced in some way, shape, or form at some time. If we look across the ocean at the British Thoracic Society, they too have recently come out with recommendations in 2012 for the care of children this time with neuromuscular weakness. And their recommendations are a bit broader, but they suggest that children with a weak cough should be taught how to do airway clearance, that a manual cough assist and air stacking methods to achieve MIC are effective, and that they should be used when appropriate, although they don't define when appropriate might be. And mechanical and exsufflation should be used if the patients are very weak, if they have loss of bulbar function, meaning that they have difficulty holding that air in their throat and in their lungs, or if they're not cooperative with the manual technique. And that's effectively what we've done in our own practice as well, and certainly should be used during respiratory infections or hospitalizations. But as I've told you, the implementation of these guidelines, which in fairness are not very clear nor very evidence-based, has been very varied. And in all of these guidelines, they make the statement that more research into this therapy is needed, that we don't really know how best to roll it out and in whom it's most appropriate. If we look closer to home at what's happening, I think things are shifting, and I think that lung volume recruitment and airway clearance techniques are being brought more to the forefront in our own country in children. We did a survey in 2010 looking at practice across the country, and we surveyed pediatric respirologists. We also surveyed pediatric neuromuscular specialists. So the neuromuscular specialists are in the light blue and the respirologists in the black. And we asked them how and when were they using these types of techniques. There were very few who were never using it, so most people agree that it's useful in some scenarios. There were certainly being used more frequently during hospitalizations for respiratory exacerbations. Some were using it during outpatient managed respiratory exacerbations, and when we got into it further, access to this type of therapy on an outpatient basis probably drove some of the yeses or nos in terms of whether people were using it. During clinical stability, whether this was being used as a chronic therapy on a regular basis, there were actually very few that were using it. And what we found was that 18% of the respirologists, who were all centered at 3 centers across the country in 3 different locations, were using lung volume recruitment twice a day during clinical stability, and only in a minority of their patients, so 33%. So very select population, and really only a few people who were driving this as a regular therapy, which is understandable, given that we don't know a lot about how beneficial this is going to be. And really, it's one other thing to do in an already busy day. But I do think that there's some benefits to be had here, and if we can answer the questions of how best to use this treatment, we probably would have a more effective way of rolling it out. So we don't know in the long term how beneficial this is if we use it on a regular basis. We don't really know what the optimal time to start this treatment is or how often it should be used. And we also don't have a head-to-head comparison of the different devices. So I hope we're going to be able to start answering those questions, and that's really the basis of this study that's starting to roll out across the country now. We've titled the study Steadfast in the hopes that it's going to keep pulmonary function steadfast and not declining over time. What the intent is to look at stacking exercises, lung volume recruitment with a manual resuscitation bag, and looking at how they affect the decline in forced vital capacity or lung function and sick time. There are a number of different investigators involved in this project, and there are now 14 sites that have signed on across the country to be part of this study. The study is rolled out initially in Ottawa, where it's being coordinated, and has started in Calgary. We're hoping in the next few months it's going to start in the other centers as well. And the study really looks at randomly assigning people with Duchenne muscular dystrophy who are between 6 and 16 years of age to either doing their regular therapy or doing their regular therapy plus using lung volume recruitment twice a day on a regular basis. And we're going to be looking at how that affects the rate of pulmonary function change and hospitalizations, antibiotics, and quality of life. Okay. So now we're going to change tacks a little bit. It's enough about the airway clearance and lung volume recruitment stuff. And we're going to talk about nighttime breathing. And here is where I think you'll notice a bit of a departure between Dr. McKim's practice and mine. We're fairly aligned on most things, but in terms of how we regard the sleep lab as a tool, I'm, I think, a much bigger proponent of its use in this population. So again, we're looking at a situation where somebody who during sleep doesn't breathe as deeply as when they're awake. And that's true of all of us, but if you have weak respiratory muscles doing a lot of work during the daytime, you may not be able to quite keep up at night when you're sleeping. And with that in mind, sometimes the breathing can be too shallow to maintain oxygen levels and too shallow to clear out carbon dioxide. And certainly, if children or young adults have scoliosis that further restricts their chest wall or obesity, those things too will make it an extra load and that much harder to breathe during the night. The first thing to recognize, though, is that sleep-disordered breathing, either underbreathing or blockage of the upper airway during sleep, is very common. And in neuromuscular disease, it's very common. So one study looking at how prevalent it was found that in over 40% of the patients they looked at, it was there in some way, shape, or form. And in some way, shape, or form, gas exchange abnormalities, so oxygen in and carbon dioxide out, were affected, and sleep was disturbed in over 80% of patients with neuromuscular disease. In general, if you look at the prevalence across the population, it's 10 times greater than the general population. So it's something we should be watching for and something we should be looking at. How that manifests depends a little bit on the respiratory muscles that are involved. If the problem is maintaining the upper airway muscles strong enough to keep that airway open during sleep, then the patient may have obstruction of their upper airway or obstructive sleep apnea. If the trouble is that the muscles between the ribs and the muscles of the diaphragm are too weak to take deep breaths, then it presents as hypoventilation. In general, there tends to be a progression, at least in Duchenne muscular dystrophy, where obstructive sleep apnea may be present first, and then the underbreathing comes later. So testing for this is a challenge, and it's a particular challenge in children where teasing out symptoms from them can be more difficult than in adults. So in terms of the tools and the things we have at our disposal to try and understand if somebody has sleep-disordered breathing, we have daytime tests we can do and nighttime tests we can do. We'll talk a little bit about looking at symptoms, pulmonary function, and blood gases, and then we'll talk about overnight oximetry and polysomnography or sleep studies. And finally, we'll get back to treatment. So as far as symptoms are concerned, I will tell you that most of my patients who have been found to have sleep-disordered breathing had very few symptoms. Sometimes they'll tell me that they have morning lethargy. They're feeling like it's hard to get going in the morning and they're just exhausted. Sometimes they'll have headaches, and that's a big warning sign because that can be associated with carbon dioxide retention. Sometimes they'll have poor growth. Rarely, I'll have children who say that they're afraid to go to sleep because they know they have breathing troubles when they're sleeping. And generally, we get this vague description of, I'm not a morning person. Now, in many of the patients I see, this all evolves around the time they hit their adolescence. I think any one of those, not a morning person especially, could be attributed to most adolescents regardless of their health state. And some of them, it creeps up as their disease in general is progressing and the other muscles are getting weaker. And it's often very hard to tease out what is related to a sleep and breathing problem, what's related to the overall change in their course of illness, and what's perhaps in some cases related even to generalized anxiety. So because this all develops very slowly, it's hard to piece together. And in truth, the majority of patients who have a slow disease progression are really asymptomatic. And it's only once you identify the problem and treat them that they come back and say, wow, I guess I really wasn't sleeping very well. I feel so much better now. And I hear that often. But with that in mind, it makes it very hard to know who to screen, how to screen, and how these symptoms are really going to be predictive of the sleep and breathing problems. So people have tried looking at pulmonary function tests as a way of identifying who should be screened for sleep-disordered breathing. And the first study that was done in boys with Duchenne muscular dystrophy who were a bit older. They were over 12 and had fairly advanced course of disease. They all had lower forced vital capacities, and in this case they used FEV1, and found that if they were less than 40% predicted, that they were associated with sleep-related hypoventilation or that underbreathing. And certainly there was a trend that as your lung function declined, the risk of having the underbreathing increased. But as I've told you, in kids, many of them are asymptomatic. So we decided to approach this a little bit differently. We looked at an asymptomatic group of children with a variety of neuromuscular diseases, and we included kids between 6 and 17 years of age, and we screened them all for nocturnal hypoventilation. So they all had sleep studies, they all had their breathing tests and questionnaires looking at symptoms. We tried to predict who was getting into trouble. And what we found was kind of surprising, first, or not surprising, I guess depending on which side of the coin you're looking at it from. But the prevalence of this undetected nocturnal hypoventilation was 15%. So these were kids who said, I'm fine, there's nothing wrong, I'm doing quite well at night with my breathing, thank you, and 15% of them weren't. We identified a higher threshold of pulmonary function below which the risk of breathing problems started to creep up. And we found that an FVC less than 60% predicted or an FEV1 less than 65% predicted should be the threshold at which we should start to think about nighttime breathing problems in our patients. Now again, what's different here is that we don't really know when this is all happening, but the first study identified patients who were starting to have daytime breathing problems as well as nighttime breathing problems, so much more advanced in the disease process. If you look at those that just have that isolated nighttime breathing problem, you have to look earlier, and they may not be symptomatic yet. So we know for sure that the risk of hypoventilation increases as pulmonary function decline happens. We don't exactly know what the true cutoff is of when this begins, but in general, we need to start thinking about it when the kids or young adults reach an FVC of below 40 to 60% of predicted. People have also looked at blood gases as a way of predicting hypoventilation or breathing problems at night. And I will tell you that we tend not to do blood gases in children. It's a painful procedure, and we try to avoid pokes and blood tests as much as possible. We can measure carbon dioxide level with an end-tidal CO2 monitor, so a little set of nasal prongs, and we do that at every clinic visit as well. So we do get an indication if the carbon dioxide is starting to rise. Certainly, if that number is going high, so the 45 is the upper cutoff of normal, if it's abnormal, that's a big red flag, and that patient or person should be looked at in terms of whether they might have a nighttime breathing problem. But again, since we know that this starts to happen as an isolated nighttime event before the carbon dioxide goes up, this is a late finding, and we probably need to be a bit more vigilant than relying solely on the carbon dioxide levels. So in terms of how to evaluate this, I have to tell you I'm a bit spoiled at my own center in that I have access to a sleep laboratory. Granted, the wait list is phenomenally long, but in some places there may not be access to the ideal type of testing that we have at ours. And there are different options out there, and lots of information can be gained from different types of diagnostic tests at night. The first is an overnight oximetry, which is a recording of just the oxygen level overnight, which is very helpful and certainly will identify children or young adults or adults who are getting into a lot of trouble with their breathing. But in some who have the beginnings of a problem, they may actually wake themselves up before their oxygen levels decrease. So they may be having a poor quality sleep where they're waking up often at night, and you'd miss that from an oximetry test alone. The other thing that's come up in the pediatric world is that if you measure capnography, which is a way of measuring carbon dioxide trends through the night, sometimes the carbon dioxide goes up without the oxygen going down transiently, and again, it's a more sensitive test. So if you add that in, you increase the odds of identifying someone. I don't know of any pediatric centers that are actually using this combined approach, but it's certainly advocated in many places in the States. Home sleep studies have caught on really well for adults. In the pediatric world, they just haven't caught on, mostly because kids tend to pull things off as they sleep, and it's hard to get a useful reading, and they don't record carbon dioxide, so you may miss things. We'll talk a bit about polysomnography, or in-hospital sleep study, which is really the gold standard. And then there's a lot of information nowadays that for children who are on nighttime breathing support, the machines themselves carry a wealth of information. They all store information about breathing patterns and gas exchange as well that can be useful tools to follow patients in the clinic. So this is what somebody set up for a sleep study would look like. And what it records is EEG, so they're little stickers that are glued, literally, onto the patient's head. Those record what stage of sleep they're in and let us know if they're in dream sleep or whether they're awake or whether they're in different stage of sleep. There's stretchy bands around the chest and the belly that help us to look at how deeply somebody's breathing. They help us look at respiratory pattern and whether somebody's stopped breathing or whether they're breathing very shallowly. Oxygen saturation is recorded as well. Carbon dioxide is measured, and you can't see it, but there's a little prong that goes under the nose and a little sensor that goes on the skin to measure that, and movement is tracked as well. It's the most comprehensive way of monitoring somebody. There's nothing painful about the test, but it's a pain. It requires a night in hospital and a close set of watchful eyes that are trained to evaluate it. One of the biggest advantages is that the patient is under constant observation by somebody who's trained in sleep so that they can intervene immediately if there's a problem. They can try different approaches and test things out. So if a problem is identified, the next step is to use non-invasive ventilatory support. In general, for children, this is bi-level support. So as you heard from Dr. McKim, that constant positive airway pressure is really only helpful if the issue is a blockage of the upper airway alone. As soon as somebody has difficulty generating a deep enough breath, then a bi-level support is what you want to provide. And what we set is the amount of pressure that somebody gets when they take a deep breath. So they try to take a breath, and the machine pushes more air up to a set pressure maximum. And when they breathe out, a certain pressure is maintained. That's the expiratory positive airway pressure. And that helps to maintain the airways being open. And we can also set a respiratory rate so that if somebody's breathing regularly, it's not a problem. But if they have pauses or their respiratory rate declines below a certain level, then the machine will also provide the support of adding, some breaths to make sure that they breathe enough during the course of a minute. If we look at the benefits of non-invasive ventilation, it's been very well documented that this is a beneficial therapy for a variety of conditions. We know that it can prevent the need for invasive ventilation if somebody's acutely unwell. We know that it improves oxygen and carbon dioxide levels, and that was the study that Dr. McKim showed, that when you provide the therapy, the gas exchange improves, you take it away and things don't look so rosy. We know that it can decrease hospitalizations and intensive care unit stays for chest infections. A long time ago, we looked at this and found that in the year after initiation of non-invasive ventilation in children, compared to the year before they were started on it, they had 85% fewer days in hospital and a significant reduction in the amount of time spent in intensive care. So in addition to improving the nighttime breathing, this also has benefits in terms of supporting people through respiratory infections. Now, the when to start is a tricky one, and the decision is really based on the severity of the nighttime breathing problem, if we know about it, the presence of nocturnal hypoventilation. Some children we've started when they've had recurrent pneumonias or areas of atelectasis or collapse of the parts of the lung that aren't responding as well, or they're happening more frequently than we think they maybe ought to. And certainly if there's evidence of a high daytime carbon dioxide level, that would be an indication to start. The therapy is generally quite well tolerated in children as well as in adults. And the main things that we watch out for are that the bilevel therapy is applied through a mask that goes over the nose or over the nose and mouth. And because it's a mask that's applied quite tightly to deliver a pressure, sometimes it irritates the skin. So in particular, it's the nasal bridge that tends to get irritated as the mask rubs. There are a couple of things that we can try to mitigate this. The first is to adjust the mask itself and the straps. We're somewhat limited sometimes for smaller children in the types of masks that are out there, and there aren't very many options, so we've had to customize things in the past. Fortunately, slowly we're starting to get more options for children in that realm. Frequent cleaning of the mask is important because the oils from the skin can actually be quite irritating, and reducing that will prevent skin breakdown. And finally, there are a number of protective skin dressings that can be used to prevent it from rubbing in certain spots. The next thing that we watch for is abdominal distension and aspiration. So some of that air that you're giving through the nose or through the nose and mouth, in addition to going into the lungs, is going to get swallowed into the stomach, which can make people feel bloated or gassy and uncomfortable. And in theory, could, if it stretches the stomach enough, make them vomit. So we want to avoid that, obviously. And if they have a G-tube, we try not to do feeds at nighttime. We try to stop them for a couple of hours before the BiPAP goes on at night. And if it's possible to keep the G-tube open during the night, we'll do that as well to let air escape. Excuse me. The other thing is that if patients have heartburn or reflux, that you really want to make sure the treatment for this is optimized so that it's not exacerbated by the presence of the BiPAP machine. One of the things that's going to really guide success with this treatment is having a good mask seal and a mask fit. And again, there are a few options out there for small children, but there are more becoming available, and sometimes just trying out different ones will make the difference between somebody who really finds the machine uncomfortable and someone who does very well with it. We try to use just nasal masks, although in some children, a mask that goes over the nose and mouth is necessary. The nasal mask is a little bit of safety in that if the if the patient were to throw up, we want somewhere for it to come out. Whereas if the whole mouth and nose are covered and the child or a young adult is not able to remove the mask themselves, in theory they could inhale some of that. So if a full face mask is used, we try to put in place extra monitoring just to make sure that that safety is present. And in terms of preventing or encouraging comfort, rather, humidification of the system helps to prevent drying out of the nose. It's a lot of air going past there, kind of like sticking your head out a car window. So we want to make sure that we keep things as comfortable as possible. And it also helps to prevent the secretions themselves getting dried out and thicker, which makes it harder to cough them out. Best part of my job is I get to play. And with kids, introducing this as a play or a toy or a gadget often goes a long way to gaining acceptance of something new and something that's coming at their face. We have lots of scuba divers and astronauts in our clinic who have tried this out, and it's been quite successful to get them used to having the mask itself applied over their face. And really, tolerance does tend to build over time. Patience is needed. So I will say, in particular, individuals with neuromuscular disease tend to acclimatize quite well to this therapy, and more so than other patient groups. I think in large part because they have the insight to know that it makes them feel better. And if you can just get over the hump of the first couple of days of where it feels a bit weird and it's something new, then you really do get by, and they feel better with it and aren't as troubled by having it. And certainly the kids can tolerate the masks and can do well with this therapy. You heard a little bit from Dr. McKim about options for when the nighttime support alone isn't enough. And certainly we have some older teens where we've used mouthpiece or sip and puff ventilation during the day. We did have one young child who was 5 years old who was able to successfully use this therapy. It requires a lot of training. A lot of investment from families and as well from the healthcare team to get it right, but it can be done. In terms of how we evaluate non-invasive ventilation, we want to look at how comfortable someone is wearing it and how much they use the device. That's often very telling. If it's not comfortable, nobody's going to use it. It has to actually make them feel better to buy in and to be willing to follow through with it. We look at the work of breathing, and we also look at blood gas exchange, oxygen levels, and carbon dioxide. And what we're looking for is an improved respiratory pattern, less work on the part of the individual to achieve the gas exchange, less work of breathing, less respiratory infections, and certainly improved quality of life with better energy during the daytime and better sleep quality. To end, I'll just give you an example of how all of these therapies can fit together to work for a patient. So this was a lovely young man who at the time was 14 and had Duchenne muscular dystrophy. I had the pleasure of seeing him in clinic after a 3-year absence from the clinic. And in the interval between his last visit and the time that he came back, he had gone from being ambulatory to needing a wheelchair full time. In the year before he saw us, he had 2 pneumonias requiring antibiotics and had 1 fairly prolonged hospitalization with an intensive care stay. He came in complaining of daytime fatigue, morning headaches, and generally less energy. If we listened to him, we heard this constant gurgle in his throat, and that's what he described as the most troublesome thing for him. And he was able to articulate that he had difficulty coughing stuff up. In the interval from our last visit, his forced vital capacity had dropped from 70% of predicted to 40% of predicted, and his cough, if we asked him to cough in clinic, which is something I'll often do to get a sense of how strong or weak a cough is, was really quite weak. So we taught him how to do lung volume recruitment. We initially did it with the manual ambi bag, and later he went on to have an anexaflator. He was, did something bad. He was taught to use this twice daily. We did a sleep study that showed severe hypoventilation, and we started him on nocturnal non-invasive positive pressure ventilation. And over the subsequent year, despite the weakening of his other muscles and clear progression of his overall neuromuscular condition, he was able to clear secretions well. He didn't gurgle anymore when he came back to clinic. He had 3 colds that he handled well. He still got colds, but they didn't turn into pneumonia. He had much improved daytime energy and no more headaches. And most importantly, he came back and said, wow, I feel so much better. So these tools are there. They can be used. I think that as time goes on, we'll have a better idea of how and when to use them and in whom. But certainly there's a lot out there to support respiratory problems in people with neuromuscular conditions. I think I'll stop there and answer any questions.
I have 2 questions, actually.
Sure.
First of all, do you test a sleep study with, like, a pre-post? Do you ever do one with before BiPAP and after?
Yes. So what we will do is we'll do one study as a diagnostic test, so to try and figure out if somebody has the hypoventilation. Depending on what we find during that study, sometimes we'll initiate therapy during that study. But we also use the sleep studies as a way of monitoring effectiveness. Because things change over time, we do follow people. So initially, again, we have the luxury of a sleep lab that's pediatric and dedicated at our hospital, which makes it easier to access. But we will do a sleep study 3 months after initiation, at 6 months after initiation, and then probably every 6 months to a year after that. In the younger kids, because they're growing more rapidly, we tend to do the studies more frequently. In the older teens, we probably need it less as things evolve a bit more slowly. But we're also learning that we can get a wealth of information from the machines themselves. So now that we have the ability to download information from the bi-level machines themselves, we can see whether things seem to be going well, in which case we can delay the next sleep study, or whether there might be an issue, and then we can move things up. Now, I say that recognizing that not every centre in Ontario, and certainly not across Canada, have access to such tools. And again, in the US, they're not necessarily doing this as a regimented plan of care. I view it as another tool. It's ideal. If it's available, great. If not, you make do with what you can have, and it's not 100% necessary in order to be able to initiate or follow somebody on non-invasive ventilation.
My second question is, to measure the MIC and forced vital, how do you measure that so that you can get this ratio different?
Excellent question. We're still trying to figure it out. So to be honest, we have not been routinely measuring it in our patients. One of the challenges is that getting somebody who's younger to hold their breath in order to put the device to measure has been a challenge, and we're still figuring out how best to do that. So it's not something that we've routinely measured.
But technically you could do it with a peak cough flow
You
meter
could.
with the breath stacking and without it?
Yes, and that's the intent. That's exactly what we're intending to do. We've tried it in a number of our patients recently because we're trying to implement that as one of the outcomes we're going to look at in the larger study, and it's been a little hit and miss as to how effective it is. But for those where you can measure it, it's again something else, an additional tool that you can use to monitor things over time.
I'm not sure. Oh, okay, my microphone's on now. I have a slightly different question. I'm wondering about if you have recommendations about sleep and positioning at night and how that can also help along with the equipment or without equipment.
It's a very good question. So there is not a lot of evidence or study to help guide that answer. Certainly somebody who's more upright will have their diaphragms at a mechanical advantage. So if you're upright, your diaphragms are pulled down by gravity, which helps you to breathe a bit better. It depends a little bit on what the source of the breathing problem is. So if the issue is purely upper airway obstruction, that picture Dr. McKim had of the cat on the back, not the way you want to go. When you're lying back, that's when things flop inwards the most and obstruction will be worse. For somebody with hypoventilation, I don't think we really know whether position makes a difference or not, other than that upright might be a bit more helpful. And it's a tough thing to say that position alone would be enough for somebody who has a significant breathing problem at night.
Hi, I have one comment, one question. One comment being that most provinces don't fund respiratory equipment. However, New Brunswick does have a government-funded respiratory equipment program, which I'm very proud of.
You should be proud of it.
My question is, a lot of the children that I see, they do get, or they try to get, pulmonary function lab tests. A lot of them have a very difficult time with lip seal. And so because they don't get lip seal, oftentimes in the lab, then the study's inconclusive, or they don't have any modification to be able to get any reading. So I guess, what are your comments on that?
I think what you bring up is very true, and we encounter the same problem as well. There are some mouthpieces or bite-type devices that can help to improve the seal, but they're not perfect. And sometimes it is a real challenge, and we can't rely on the pulmonary function tests. I think any one of these tests in isolation is not a panacea. It's not going to give you a complete picture of somebody's respiratory health. It's another tool and another thing that you can use to guide treatment. Ultimately, it boils down to the person sitting in front of you. And I will tell you that as much as we look at the numbers from the pulmonary function tests, in the clinic I'll ask somebody to cough as hard as they can for me, and that's just as telling, if not more telling, about how effectively they're going to cough as a number. And we don't measure peak cough flows on a regular basis. So I think I agree with you. It's challenging at times. It's helpful when you have it, but otherwise it's not the only thing that you can use to guide treatment.